The best way I can explain it is the concept is akin to your house is on fire, and now I'm going to go get homeowners insurance.
Yeah, no kidding.
I mean, it's that profound.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare. So I'm sitting down with Kevin Chambers. You are the SVP and Tribal Practice Leader at Lucent.
Yes.
Is it Lucent Health or Lucent?
Lucent Health.
Lucent, yeah, Health. Great administrator, partner of Pareto as well. So thanks, Kevin, for joining me, man. So quick trip up from Austin, right? Not too bad. I've done that flight before. It's 35 minutes maybe, right?
Barely have time to put your tray down.
Yeah, I looked at you and go, hey, where's your bag? And you're like, I'm on a day trip, man.
Right.
Yeah, I feel you, though. Sometimes on those day trips I take, I'm like scared that I might get stuck overnight and don't have a change of underwear. It's happened. But thanks for coming, man. I really appreciate this. Kevin, why don't we just define what we're going to talk about, and then I'd like to go into your backstory and who you are. But we're going to talk about this idea of this tribal space within healthcare,
right,
that not a lot of people are aware of some of the subtleties of it and some of the opportunities. But how would you best sort of position what this episode's going to be about?
We're going to talk about components. There are very distinct entitlements that are sponsored by the federal government for tribes to subsidize, if you will, further subsidize tribal health care.
Yeah, and you were telling me about the pillars, and we'll certainly cover those in a moment, but really interesting opportunities for claim savings, even claim avoidance, controlling high-cost claims. It's really, really interesting. And I think based on our conversation this morning, not a lot of people are aware that these things exist. So I'm very excited to cover it. But let's go back in your timeline, man. Obviously, you didn't wake up one day and decide you were going to specialize in tribal practices. So tell me a little bit about who you are, school, career, all that good stuff.
Yeah, every once in a while, a blind squirrel finds a nut.
Yeah, fair enough.
I'm a blind squirrel. I started in San Diego, where I was born and raised. Went right out of school to work as an insurance agent with New York Life.
New York Life, all right.
Selling across the kitchen table.
How'd you do at that?
I did real well because I didn't know any better.
You're just kind of naive and want to make money,
I was told by my manager that my niche market is either 5 years older or 5 years younger. Well, 5 years younger, they'd be 15.
Yeah, so they're not buying life insurance, right?
Right. So I carved out a niche called what we called the newlywed couple. So I'd go out to the courthouse every Monday, go to the microfiche machine, get a reel, and write down all marriage certificates from the following weekend.
No kidding.
And then back then, you could call 411 and get three numbers at a time.
Okay.
And so I'd go through my yellow pad and get as many numbers as I could. And Wednesday night came along and dialed them for dollars.
Well, that's funny because that's way back before qualified leads would get dropped in your lap, right? You're literally going, and that microfiche is it kind of like a laminated thing you look through? I know exactly what you're talking about.
Roll tape, film tape.
So you get your leads, then you get four, and then you just keep calling 411 multiple times?
And then, usually...
How many leads were you getting a week then?
80.
80, okay.
And so I'd take 80 and whittle it down to 30. And that I actually get numbers on. Then I'd call those 30 and, hi, I'm your New York Life newlywed representative.
Well, I bet they love, he's our newlywed representative. He must be very good at understanding our situation. So it sounds like you had success at that. How long did you do that?
I think about 3 years.
Okay.
The difficulty with direct selling life insurance, the knot in your stomach never goes away.
Yeah.
It never goes away. You just feel like you're on a treadmill.
Well, especially at 3 years of tenure, that's probably 2.8 years longer than most guys last, right?
By 6 months, there wasn't a single person left in my class.
Well, but that's interesting, though, because you, in a situation that really the odds are stacked against you, you found a really unique way to make it work. And 3 years is, again...
I was just dumb.
You're just dumb. Well, hey, let that be a lesson to you, kids. Just maybe be dumb. But after New York Life, what'd you end up transitioning into?
And property and casualty agency, a large agency. And I again, They needed an EB benefit producer, and I said, well, I can do that.
Yeah.
I didn't know anything about it.
Well, how'd you learn EB then?
Just by knocking on doors and going to see the PNC clients and pretending like I knew what I was doing.
Well, how did you discover self-insurance at that point? Or?
I discovered self-insurance after I moved out of state to Mississippi.
Okay.
With my wife. She's from there. And
well, San Diego to Mississippi is a little bit of a transition.
A little bit.
Yeah.
A little bit of a culture shock. And I just got dropped there, and I went to work for a small property and casualty firm again. But then I was introduced to the Hospital Association.
Okay.
And because I was west of Mississippi, I must be an expert or something. And I didn't know anything what I was doing. So I'm running, our TPA.
Okay.
On the sales and marketing side.
So the hospital system itself had its own TPA.
Correct.
And how many hospitals were in that?
67.
67. Wow. Okay. And what was your role, right? So like what were you
Selling.
Selling.
Selling service.
Okay. You did that for 10 years or so, right?
I did for about 10 years. And we developed some new programs, some worksite stuff, and it was great. Very cool. Learned a lot, more than I can ever imagine.
Well, that's what we were talking beforehand off camera, right? And there, even one of the reasons I do this podcast is simply because there isn't a real program to follow to learn self-insurance. Just sit down and learn it, right? Even with some of the other great resources out there, you can get pockets of information, but you don't have a book to study that says this is what self-insurance is and this is how it works. So you kind of have to learn on the job.
Yeah,
right?
and then when I moved back to Texas, or went to Texas 25 years ago, I started working for TPA. And again, didn't know what I was doing, but and I realized I didn't have a captive audience.
Okay.
So I got to go out and hustle brokers. And so I developed a self-funded 101 course.
Oh, you developed your own self-funded 101.
And,
Okay.
Gave it to the Department of Insurance, got approved. And I could give out credits, and so I go to agencies and set up classes.
And do CE credits?
Mm-hmm.
Yeah, I've done the same as well, and I found that's a really
great
way to get in front of consultants, right? Because obviously everybody there has their licenses they need to maintain, but it does feel like a give, right? Hey, I'm going to teach CE.
Right.
I'm not going to talk about my product at all, right? And then eventually they go, oh, well, that guy was nice and he seems pretty smart. Why don't we do business with him too?
You kind of come through the back door. You're not gunning at the head producer. You're basically talking to the support staff, which will filter you upward.
Well, and the support staff is the one, you really have to win over account management, account executives, the folks that manage the actual day-to-day business. Because if you're not on their good side, there's no way that they're going to hem and haw.
You ain't getting through the door.
Yeah, you're not getting through the door. Even when we found too, is even when producers or practice leaders are sold on an idea, multiple stops in my career, they was sold on an idea and say, yes, this is great. If it doesn't have an exemplary sort of onboarding experience or service experience for the account management staff, that'll go right back up and they'll say, hey, I don't want to do this anymore.
Right.
The producer all of a sudden changes tune. So very intuitive. And you were making fun of yourself to say, hey, I doesn't know what I was doing, but I signed up for it. I think, to me, that's a testament to your willingness to actually make yourself uncomfortable and learn something new. It's a great lesson for people to hear.
Along the way, I became very proficient at stop loss and TPA work, and worked for about 4 different TPAs over the years. And my stop about 15 years ago, I was hired by HealthSmart.
Okay.
And to be in sales, and did that for 5 years. And to be honest with you, at that point, the whole transactional part of healthcare, what we do, I was bored.
Yeah.
I was absolutely bored out of my mind. And I said, I got to find a niche. And
so you went out looking for your own niche.
Well, I stumbled upon it.
You stumbled upon it.
Yeah.
Okay.
Our company was we were doing a lot of mergers and acquisitions, and one of the companies that we purchased was a TPA in West Virginia.
Okay.
That was a fiscal intermediary for Medicare.
Okay.
And so we acted as if we were Medicare as a payer.
Okay.
And we paid claims, and the participant didn't know any different. And so we did that, and I said, well, this is interesting. I didn't even know it existed.
Yeah, you're the first person to tell me that existed.
And so I dug into that a little bit and found out the rules and regs, and stumbled upon a law called Medicare Modernization Act.
Okay.
Which is about 17, 18 years ago. It was, in reality, it was a way for the federal government. There's a caveat in there pertaining to Native Americans.
Okay.
And there's a way for the federal government to reduce their obligation because they could mandate reimbursements at Medicare.
Okay.
So we're the federal government, and we're going to pay you Medicare.
Yeah.
So out of that law, came the ability for Native Americans to be reimbursed at a Medicare-like rate.
And did somebody introduce this concept to you? Did you go actually read the law? Or?
I read the law.
Okay.
And I uncovered it. And I said, well, that's interesting. Who's doing this?
I'd imagine nobody at the time.
There was zero.
Zero. Okay.
Zero. And so we developed a program where literally set up an eligibility file set on our system, where you have male, female, dependent status, et cetera. We just added another column.
Okay.
And native or non-native.
Native or non-native, okay.
And so at the point of adjudication, the claim comes in, we know if they're native or non-native.
Okay.
And if they're non-native, they get paid at a Medicare-like rate, the provider does, with no balance bill.
If they are non-native or if they're native?
Native.
Yeah, native. Okay, so if they're native, they get Medicare-like rate, which really just means Medicare.
Medicare.
Right? Okay. And
then,
no balance billing.
And then we partnered with Blues or whomever as a network, so for the non-natives, they would get paid at network rates.
Okay. Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments. Well, I'm going to go into those pillars because I know that's kind of pillar one, and I think those 4 pillars will probably shape 20 minutes of this conversation. But I do want to ask about setting up and finding that first tribe to understand this relatively new or completely new idea, right? So how did you go and source business for the first time?
There was a gentleman that I was introduced to out of, he was a tribal healthcare attorney out of Arizona. And he heard about what we were doing and wanted to come visit us. And so we laid out our solution to him. And he says, this is what I've been trying to get the carriers to do for the last couple of years, and nobody will do it.
Mm.
And so he says, I'm going to introduce you to my client, and it happened to be the Gila River tribe in Arizona. And on our way there to go meet with Blue to convince them that they should work with us, he says, you're going to need to work with Blue Cross.
Huh.
I said, that's just not going to happen.
Yeah, I would imagine they're open to this.
They're the, evil empire.
Yeah.
I mean, there's no way. So we signed NDAs and met ivory towers of Blue of Arizona. And I said, we can't do this. And I said, well, yeah. I know that. He says, but we're going to grant you access.
Interesting.
So that opened up so many doors.
So they just granted you access to their network to be able to do the program that you guys were wanting to establish,
correct.
Right? Rather than them do the program.
Right.
Okay, so that access is what you needed, right? Yeah.
Terribly bad.
Yeah.
I didn't realize how big it
Because
was.
does you kind of jokingly said the evil empire, but does the Blue Cross logo matter to tribes? Okay.
A lot. And then that led to another tribe in California. Of course, it's not Blue Cross Arizona. Now I got to go work with Anthem. So same dog and pony.
Yeah.
And we got access to them. And then which gave me 12, 13 states that are not all tribal. So, Montana wasn't in there. But then we were introduced to a tribe in Oklahoma, and they wanted our solution. They were with Blue,
Okay.
ASO,
All right.
and the chief basically said, we want to do this and continue our network.
Yeah.
And that just set the ground on fire. And so we got
So if
access to HCSC.
if you're a tribe, then that chief basically said, I want to do this. And basically, you're going to allow me to do this, is what he was saying
Exactly.
to the Blues. What was so appealing to them that was different, right? Like, why were all these tribes, the tribe?
The tribe?
Yeah.
Just because of the entitlements that we outlined. And back then, when we started, really the only advantage was the Medicare-like rates.
Okay. So to that point, even though the law or the Medicare Modernization Act allowed for it, nobody was granting them the ability to do it, right? So it's almost like, here is this entitlement, as you called it, but nobody's offered it to me before.
Right.
You better honor it. It's a federal mandate or law, I guess. So, okay, so let's go over the pillars now, because I think those will really construct the rest of the conversation. Let's continue with pillar one, obviously the Medicare-like reimbursement. So describe that to me.
And when it started, it was specifically for facility only. So having a network of physicians that was recognizable was important, because we would pay the natives who were just seeking professional services, we would pay them at the network rate.
Okay.
And, as time went on, and so that's pillar one, and we saved tribes millions of dollars, millions, and with no disruption. And
but only natives, so non-natives that are employees.
so
would
in
not
theory, the higher percentage of native you have in a population, the better discounts you're going to get.
Yeah.
Yes. So
Yeah, because in Medicare, obviously, for those that follow this show, we've featured the notion of reference-based pricing before ClaimDoc's even a sponsor.
well, this is
of
the
show.
ultimate.
Yeah, this is
RVP.
ultimate, because it's literally the reference is the point that you pay, right? There's no spread or margin on top of that, which is a fantastic deal for the stop-loss carrier and the plan sponsor as well. Yeah. Because that's oftentimes Medicare is a multiple less than what's actually paid on a PPO contract.
And no chances of balanced bill.
Yeah. Yeah, so no chances of balanced bill. Why don't you elaborate on that? Because I understand why that's a good thing.
So we put the actual verbiage in the EOBs for both the provider and the participant, where it states what Medicare-like rates mean. When we first got to Oklahoma, and we started writing business in Oklahoma for a very prominent tribe, there was pushback.
Oh, I imagine. Yeah.
There was pushback. And we had one provider that just wouldn't hear of it. And I got my attorney, which is the gentleman that I used in Arizona, to come out and shut them down. And,
as I say, do you want to take on the federal government? Because that's pretty much who you're disagreeing with at that point.
And they folded their tent and went home.
Okay.
Not their DB, but their tent.
Fair enough. No pun intended. Yeah. But so the no balance billing, I imagine though early days you're having to educate a lot of these providers, right? Because it wasn't like, oh, okay, Absolutely. You're right, and here's Medicare. Yeah. So would you have a lot of back and forth of negotiation?
Yeah, but once we penetrated the market, it went away.
Yeah.
And I have no issues anywhere where I go today.
Okay.
They understand. And they get it. So that's pillar number one.
Yeah. So pillar one, all right, so what's pillar two then?
Pillar two is through ACA, there was another caveat in the law that basically said that a tribe has the ability to sponsor a tribal member to the exchange.
Okay.
And they can do that every 30 days. So as the administrator, we're monitoring the diagnostic coding. And, you don't just wake up one morning and get a hip replaced. So the reality is that we're going to know on the front end if an upcoming event's going to occur.
Sure.
Such as, I, in theory, should never have a preemie baby, tribal baby on my plan, because I will have already escorted
So
them to
is
exchange.
are there certain life events, right, or what are triggers to allow for this to happen?
What basically is the diagnostic coding.
Okay.
We know what's coming down the pipe.
But is there restrictions?
No.
I mean, no. Okay, so there's not even restrictions on it. So then,
I mean, you can't put a gun to the head of the participant.
and say you have to take a private plan.
but
yeah.
you never have them deny it because they're getting 100% coverage.
Yeah. So what's the benefit to the member themselves? So the 100%. So they're sponsoring and actually paying the premium.
They're not coming off the plan. They're just going into a secondary role, so it works like a COB.
I see. Okay.
And so depending on the size of the plan, depending on how many natives, you could have half a dozen to a dozen participants migrating on and off the plan. And once the event occurs and they've healed, okay, you can put them back on a primary.
Oh, so it's almost a month to month.
It is every
deal.
30 days.
Okay, interesting. So then the challenge here is being able to actively monitor and enroll these folks, right? Right.
Yeah, and we have the ability to do that. I have a service team that does that execution. I don't.
Yeah,
but
you're not driving out and enrolling folks. Okay.
No, but the concept. The best way I can explain it is the concept is akin to your house is on fire, and now I'm going to go get homeowners insurance.
Yeah, no kidding.
I mean, it's that profound.
Well, what that reminds me is a scalable way to, I don't know if you've ever heard of the Samaritan Fund. I've featured them. Yeah. So really, it reminds me that program obviously is very isolated for very unique cases, and there's a lot of different hurdles to jump through, and it's based on donations.
Right.
However, the goal or the outcome is the same, is that there are certain risk that now is, let's say, diverted to a primary plan.
And you can do that all day long on a commercial plan.
Yeah.
It's not necessary. I mean, I know Bart very well, and we try to do business together, but mine's absolute.
Yeah, and yours obviously, like you said, is a very scalable way to do it.
Right.
Scalable way, excuse me. But I'm thinking from the lens, and I'm going to ask the question later. Why aren't more stop-loss carriers really interested in this? But don't answer it now. But I'm thinking from the lens of a reinsurer right now, Medicare-like reimbursements, no balance bills. You have this sponsorship program that diverts effectively the highest cost risk most often.
No doubt about it.
So that's beneficial to me as a stop-loss carrier.
Absolutely.
So, all right, checking two boxes, right?
Right.
So let's finish that pillar, and then I'm going to come back after the 4 pillars and go why. Okay. But so anything else related to that sponsorship?
No, that's it. It's so simple that it's scary.
And what sort of platform is being utilized in order to help them find a plan, if you will?
I work with an outfit out of Oregon and Oklahoma called Face Rock.
Okay.
And Face Rock executes that, as well does Tribal First has a program where they can do the enrollment as well.
I mean, it's pretty astonishing that that's even possible to do, because I mean that would make the plan so much healthier. The self-funded plan obviously so much healthier as a result. Okay, so pillar three.
Pillar 3, tribes have the ability, or some tribes have the ability to self-govern their healthcare clinic.
Okay.
So they fund it. They get subsidies from the federal government, but they fund it and they have control of it. A lot of other Indian Health Services clinics are actually run by the federal government. Mm-hmm. Okay, they don't have any control of it. Where self-governed 638 is the IRS code, they have governance, and they have the ability to treat the members. Limited scope of services,
sure.
Certainly, depending on the size of the tribe and how many providers they have, and et cetera. But they can also dispense medicines.
Okay.
Okay, and it's been limited to basically the members, the natives, and they can dispense and acquire those medicines at 340B pricing.
Okay.
Which is the lowest denominator cost out there. If it's done correctly and set up properly, they can dispense to the non-natives as well.
Okay. The non-natives aren't getting the wholesale acquisition cost, but right?
The tribe can get a margin.
The tribe can get a margin on it, so it's a revenue source, or at least pays for expenses, right? But so one thing I think you were telling me over coffee is that the federal government provides funding for this and will even run the clinics, but those clinics often aren't deemed the quality of care being delivered is not high enough, so the tribes are actually setting up their own versions of the clinics.
They're taking control.
Yeah. Okay. So what are some of the issues with the federally run clinics, if you will? Just
Reputation. Really, really poor. Typically, I'm not casting dispersions. Long waits.
Okay. So like a VA-like model.
Limited scope of services.
Okay.
And
instead, they're putting up their own direct primary clinic, if you will, for a corollary. And so
they can do an OCMED too.
Say that again?
They can do OCMED too. I mean, they got a casino. They have occupational injuries. They can.
I didn't even think about that as well.
Run that too.
Well, that's fantastic, because then they're really starting to kind of quarterback the healthcare of their own plan, right?
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
And then what happens if a service falls out of the scope of that clinic itself? Then are they referring into kind of network specialists and things like that?
Yeah, they're just going to the marketplace.
Okay.
I mean, they're going to Baptist or what have you, and seeking care and then getting reimbursed at Medicare-like rates.
Fantastic. All right. So Medicare-like rates with no balance bill. I'm going to just keep refreshing this, and we'll probably make it a clip. Then we're going to say the sponsorship program that allows them to find a primary plan every 30 days for folks that might be high-cost claimants.
Correct.
You've got the 340B acquisition of drugs and running their own clinics on the site, or what would you call it, or the on the tribal location, or what would you call it?
At the clinic.
At the clinic. And then, okay, so what's pillar number 4 then?
Pillar number 4 is not well utilized, in my opinion, for the significance of it. It is called Catastrophic Health Emergency Fund.
Okay.
CHEF.
CHEF. Catastrophic Health Emergency Fund. Okay.
Right, and it runs on a fiscal year basis. It's an emergency fund by the federal government that says a self-funded tribe can get reimbursed for any claims, specific claims, in excess of $25,000 in that fiscal year.
Okay.
So the downside to the law is that it's finite, meaning that it doesn't continuously fund. It runs out at the fiscal year and can run out in September, or can run out in August. And once it's out for that fiscal year, you can't get reimbursed.
Do you know roughly how much might be allocated on a fiscal year basis? Are we talking tens of millions, hundreds of millions? Okay.
Yeah.
Okay, so let's understand the math of that. So they get reimbursed for everything but the first $25,000 of a large claim. They, though, could be the stop-loss carrier and the tribe.
They could.
Right. So let's use some basic math, right? Let's walk through it back of the napkin example. $100,000 specific deductible, okay? A $300,000 claim.
Right.
Assuming funds are available, stop-loss carrier gets all $200 that they owe back?
Correct.
And then the tribe gets the 75 of the 100 back as well?
Correct.
Okay, so I got all sorts of questions about that. But okay, obviously the limitation of funds I totally get, right? It's a finite amount of number. When it runs out, you don't want to be the last one holding the bag.
Right. So it's incumbent
relying upon
upon us as the administrator to provide the tribe regularly the data to submit.
And is there a portal or a way that you know that, hey, this is how much funds are still available, and where you can track, right? So
not that I'm aware of.
Okay, so it's really a timeliness. As soon as that claim is submitted, you got to get it filed over to the CHEF program.
Correct.
Right?
We don't, but the tribe does.
The tribe does. Okay. Right. So I'm thinking about that specifically. I might, as a tribe, raise my specific deductible and take a little bit more risk on because of that, right?
Absolutely.
And gamble with the fact that the funds are available. Right. Because why would you want to really low spec and overpay in premium?
And, what's the harm if you have a $250,000 spec and you have 5 claims,
Yeah.
okay, and you got the chef reimbursement for 4 claims, and the 5th one didn't work,
Right.
because it was out of money.
Yeah.
You're still ahead.
You're still way ahead,
Right.
right? And I would think the stop loss carriers would really want to be on top of this as well, right? Because you're talking really nice reimbursement.
It's reinsurance on reinsurance.
It's crazy. Okay. Do you know kind of what the timing is? Let's assume everything goes through, it gets submitted, there's funds available. I mean, it's
60 days.
60 days? Okay.
Yeah.
But still, in that fiscal year, then I mean, I wonder if they're counting the loss ratio irrespective of getting reimbursed, if they're still charging the group.
They need to contemplate that.
Okay, so
they may not charge for it, but it's the pool of risk. You add all those attributes together.
Yeah.
It makes a marginal risk very favorable.
Well, but so then I'll ask the question of why more stop loss carriers are not interested in this risk. And I know there's a few answers, but one I suspect is even on balance, with all those mitigating factors, is tribal business at large seen as a less healthy risk pool? It's a riskier risk pool, right?
Without question.
Okay. So then that's factored in as well. So the baseline rates or the manual rates in order to derive a final rate include the association, right, that this may be an unhealthier population on average.
And it's counterintuitive in that, so in a commingled population of native and non-native.
True. Okay. Yeah.
The higher the native population, which would be on the outside looking in, a less healthier group.
Right.
I mean, we can talk about all of the comorbidities, but there are dozens. The higher the native population is, percentage-wise, the better the risk is.
Yeah, so more attractive if all these mitigating factors apply, right? But then that really takes a party like Lucent that understands the space, right? And I know you have a couple competitors, but understands that space to be able to state the case for that case to a stop loss carrier, right? To get it written. Okay, so then what other reasons would be unattractive for a reinsurer?
Lack of knowledge.
Okay.
That has a lot to do with it. But there is, tribes have sovereign immunity, meaning that
let's explain that.
They don't mitigate or they don't litigate in federal or state court. They, per contract, it is on the tribal land. Okay, so a carrier just needs to suck it up,
accept that,
and they're going to, if there's a fuss or disagreement, it's going to be in tribal court.
Okay. Yeah, and not to say they'll be treated unfairly in tribal court, but you would suspect, I mean, that's like having home court advantage in any sort of a sporting event, right? And very likely, unless there was some egregious thing done by the tribe itself, that they're unlikely to win in that scenario if I'm a carrier, right? So you accept that, right?
Embrace it.
Embrace it. However, I mean, I wonder even how often those things actually end up. Yeah, right. I think it's, again, going back to a reference-based pricing reference, the balance billing.
And you can understand why the tribe protects themselves.
Of course you can. Yeah, of course you can, right? I mean, I can understand why United Health Group does the things they do because they're acting rationally in the interest of their shareholders. I understand it.
Right.
Doesn't mean I necessarily always want to play on their playing field, but I understand it. Okay, so sovereign immunity is a big hurdle, and you're saying some carriers, so stop loss carriers, don't touch it at all, right?
At all.
They won't agree to it, so we don't write that kind of business.
Cigna used to, not to blame Cigna, but they've since walked away from it.
Okay, right. And so what players do you know of, if I'm a broker listening and I'm interested right now in tribal business, but wondering, well, what hurdles am I not thinking of? Like who's writing this type of business that you're aware of?
Swiss.
Oh, Swiss. Okay. Yeah.
For sure.
And I would imagine there's some MGUs out there that are specialized. Half a dozen. Yeah.
And, Tribal First has its own paper through Hudson, which is, London line slip. And they've embraced it. They've embraced it not only on the EB side, but totally on the property and casualty.
Okay. And it just own anecdotal experience. I had a tribal group when I was at Sun Life. I don't know and can't speak for them if they still ride it to this day, but about 10 years ago, that was the case. So you have some big name players that are willing. So that doesn't really seem like an impediment. That's more just knowing who to go to.
Yeah, and you know how the reinsurance market has shifted over the last 10 years.
Yeah.
More and more brokers, quality brokers, are placing their own stop loss.
Yep.
And they're directing us to use their vendors, and which we can. We don't have a problem with it. But if they need help and don't have all the markets that they need, we certainly can work with that.
Okay. Well, let's talk about then let's drill down to opportunity level discussion, right? So again, thinking along the lines, I'm a consultant. Maybe I have a tribe as a client. Maybe I have a tribe that's a prospect and I don't know how to get in front of them. What would you want them to be aware of as they try to enter into an arrangement? Or because I'm sure there's a lot of things they don't know.
The four pillars.
The 4 pillars. Okay.
It's simple. I mean, and you'd be amazed how few don't communicate that.
And why do you think this space remains still so niche, right? I mean, is it difficult to develop relationships in
You don't wake up one day and say, I'm going to work with tribes.
Yeah.
And it takes, again...
I've been in this business 12 plus years. You're the first person that I've ever met that specializes in this, right? Which is why I was so eager to sit down with you. But, I appreciate sort of this willingness to share and raise awareness. Why do you think the TPA is such a crucial decision in this as well? I mean, I know we covered some of those components, but...
Being able to have the know-how and the systems in place to do sponsorship, to do MLR, that's important.
Yeah.
I mean, again, you have to be able to adjudicate properly.
Properly, yeah. And then I guess you have to have somebody that understands the legal components, right? Because if there's ever a gray area or question, if sovereign immunity is a possible risk of an outcome.
And typically, tribes will have their own tribal attorneys.
Okay.
And they can certainly direct and steer and, make sure the tribe is protected. You're going to execute contracts. And 9 times out of 10, those contracts are going to have sovereign immunity in them.
Okay. Well, and, I know you keep mentioning the property and casualty side, and I'm sure I'm the first person to tell you I barely know anything about it. However, is there a role to play in property and casualty with tribal?
Absolutely.
Okay. Is there any special rules or anything around that you're aware of?
You just stepped out on my field.
Okay. Same. I suspected that.
I'm sure there are. And Tribal First would probably be the first one to step up to the plate.
So let's, if you'll take your Lucent and tribal hat off for a second, I often ask, and we'll kind of move towards the end of the podcast, I ask my guests to, let's just be philosophical about the future of healthcare, right? You've been in this business for a while now, or most of your career, right? Yeah. So I suspect you have an opinion there, but we were joking beforehand, and I don't even know if that footage might make the actual episode, where the end has always been nigh. Right? It's always nigh. And it's been nigh since you've been in the business, since I've been in the business. And so some of it's probably overblown, but it does feel like we're in this really weird space where there's a lot of awareness of some of the inefficiencies in healthcare. And people like Fat Joe, or, he has this whole thing that they're patient advocacy. And it seems to be much more top of mind for the average American than maybe it used to.
I agree with that, and like I said, our demise has been predicted for as long as I used to say, if I can last 5 more years, before it collapses. It's been doing that for 40 plus years. At the end of the day, how much more could we squeeze out of the healthcare dollar if we were efficient?
Yeah. I would suspect 30 to 40% off the top.
If we had transparency, if we had honesty, it would be huge, and all that would filter back into the system.
Yeah.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Well, I mean, I've heard predictions, or not predictions, but basically suggestions about how many unnecessary back surgeries are performed. There's always folks that are in the payment integrity and bill review space that say at least 25% of healthcare is waste, if not more. And that's just a low-hanging fruit that they can find in errors and erroneous charges and duplicate charges and things like that. Fraudulent. I mean, I always try to avoid saying fraudulent, but at the end that you come to the conclusion, it's hard to say it's anything else but fraud, right? And so I think if anything comes out of this era of healthcare, it's exposure of exploitative practices, especially in the hospital system.
And wouldn't we support that?
I would think anybody would support it, left or right of the aisle, right? I don't think anybody would say, no, I want hospitals to hide what they're charging folks and then take them to collections, and I want payers to have their contract secret so that you can use me as a pawn to make money. I don't think anybody would agree to that on the surface, but that's where we are, right? So do you think if you were to predict, if you will, if the end is not nigh, how do you see healthcare morphing over the next decade or so?
I hope they clean up their act.
Yeah.
I mean, I think market forces will cause that. I hope, it could be a pie in the sky, but at some point, the dam's got to break.
Well, and I look at a specific example. So I recently talked about and posted about my son's ER trip, and I'm sure people that have followed this episode and follow me on LinkedIn know about it. But it amounted to, let's call it $4,000, about $4,200 of charges for a middle of the night ER trip, which was just croup, and it was just a respiratory treatment he got, and we got a $4,200 bill as a result. A level 4 ER charge. Surprise, yeah. So I bring that up to say, hey, I just posted this afternoon, it'll come out, a resolution where a company saw that post. They're called Goodbill. They reached out and said, we think we can help you. Would you let us look at the records and see what we can find? And so they used what's called an API and extracted the data out of his my chart, got it into their system, started the process, and long story short, found 25% savings and went to the provider on my behalf, negotiated it, got it signed, boom. No effort on my part, saved $850, right?
That's great.
So as an example, I bring that up to say, like, if we can scale stuff like that, then all that is going to do is that's a domino effect, right? If everybody's using a tool like Goodbill or there's other great ones out there, then the hospitals are going to have to react to that because they're getting exposed over and over and over again. Correct. And I think just if anything we can do on this podcast, if anything we can do in healthcare is just keep shining a light on exploitation. And at some point, the dam will have to break on that, right? And that's where I think we solve a lot of our problems.
I totally agree.
And that's where I think you'll see bipartisan agreement in healthcare as well, because that kind of the quadopoly of the bucas and the stranglehold they have on with lobbying, I think eventually that also has to somewhat fall apart. And maybe I'm a little bit too optimistic, but I think that's what probably will happen. Do you think the government has an expanded role to play, though? Obviously, it benefits the business that you're in.
I think, from a regulatory standpoint, forcing transparency. Yeah. I think that would be their role.
So not necessarily getting into healthcare delivery, not a single payer solution. I think anybody that sits on the couch with me or the chair with me is going to say, no, we don't think that's happening. But they're the sort of lay person in our country
make rules and regulations. You can't do that.
Yeah, but the transparency element, and they've started to try to do it with price transparency, right? And making, obviously, the machine-readable files available, but those have to be interpreted and those have to be tracked, and not everybody is adhering to that because the penalties aren't stiff enough yet, right? So some enforcement has to come along with the law, otherwise the law is not worth the paper it's written on. So anyways, we're just going to keep beating this drum, man.
And then, the threat of, more bureaucracy is looming.
Right. Oh, yeah. Yeah, because if the government does get more involved, then that means more bureaucracy, right? So I think we just have to strike a balance, but they obviously will always have a role to play in enforcement of laws. And if people or if the industry itself doesn't hold itself accountable, then them acting as a third party should help to create that accountability.
Right.
Yeah. So closing thoughts, man. I appreciate this this conversation, and thanks for just kind of waxing on healthcare in the future. But if you were somebody that was listening to this episode and you wanted to leave them with a final thought to maybe reach out to you or talk shop a little bit, what would you say?
Please do, and we can have a rehashing of what the attributes of tribal healthcare are.
Yeah.
And I'll be happy to walk you through it. Be happy to talk to your prospect. Be happy to, just spread the word.
Yeah, I'll definitely be spreading the word and after this. And when this gets posted, we'll put out a number of clips. I think I'll ask Nathaniel to summarize those 4 pillars and just make it a nice, really coherent list of those things. And hopefully that'll lead to some interest for you, man. But Kevin, thanks again for making the trip. We'll get you on your way, man. And a couple years from now, we'll probably sit down again if you'll want to and rehash how you guys have grown. So thanks, Kevin.
Thank you.